A very good evening to everyone who is joining us live on Facebook now. Welcome to the very first episode of Penang's live discussion program, Science Stream. I hope all of you are staying safe and healthy during this pandemic. We'll be starting our broadcast shortly, so make yourself comfortable and feel free to leave your questions in the comment section for our guest to answer, if you have any. Our guest is having some connective issues at University Malaya, so we hope that you'll be able to hear him clearly later, but if not, we do apologize for that in advance. Hello once again, especially to those who have just joined us. I'm Sean from Penang. Apologies for the timing of this program, but we felt it was important not to exclude our Muslim friends who are observing fasting during the month of Ramadan. We'll be moving the program earlier after the month of Ramadan. Today, our guest is someone who comes face to face with COVID-19 ICU patients, those who are at the most critical stage on a daily basis. Dr. Kevin Ng Wei Shan graduated as an anesthesiologist with a Master of Anesthesiology from the University of Malaya in 2015. He won the K. Padmaraja Memorial Gold Medal as the overall best anesthesiology candidate for his year. His love affair with anesthesiology began way back in 2008, where he was inspired to join the field after meeting the many inspiring anesthesiologists who were able to tie the wonders of physiology to clinical practice. Since graduation, he has served in Hospital Kuala Lumpur and Hospital Sultan Haji Ahmad Shah, Tebelo, before returning to University of Malaya, where he is currently employed as a medical lecturer and anesthesiologist. His interests include pediatric anesthesia, regional anesthesia in pediatrics, and patient blood management. Without further ado, let's bring on Dr. Kevin to the show. Welcome to Science Stream, Dr. Kevin. Thank you for being with us tonight.
Hi. Thank you for having me, Sean.
So, Dr. Kevin, we understand we are having some internet problems on your end. We hope that you'll get better as the broadcast moves. Okay. So, Dr. Kevin, what does an anesthesiologist do? I was told that anesthesiologists are one of the best paid in the medical fraternity. Are you rolling in tons of cash now?
Sadly, this is. It may be true in some other countries, not so true here in Malaysia. As a government doctor, whatever work you do, you get paid the same thing. But what does an anesthesiologist do? Well, anesthesiologists, we have two arms to it, basically. We call ourselves anesthesiologists, but we study the field of anesthesia and critical care. So on one hand, we are the people that put you to sleep, keep you safe during the surgery, and wake you up at the end of it, definitely. And on the other hand is where we were called upon during the COVID-19, the pandemic, the current pandemic, where we do critical care. So critical care essentially is care of patients in intensive care unit, where we provide assistance to probably the sickest of the sick. And we probably will we probably see the ones that need us most, that needs the most amount of care during this current pandemic.
I understand that one of the process involved in the ICU is the intubation process. I understand that this is one of the riskiest medical procedures for medical frontliners. Run us through why is this so?
So, okay, if we see what the a lot of the research that came out and looking back, especially from the experience in Wuhan in China, what they found was the people working closest to the patient's respiratory tract, meaning that the nose, the mouth, and the throat, okay, the ones that tend to develop or tend to get COVID-19. Okay, from their patients. So we contract COVID-19 from the patients. This is because most of the time the virus actually lives within this area, and we are intentionally putting ourselves as close to the patient as possible. So intubation is the insertion of a tube, a breathing tube, okay, through the mouth into the trachea to allow you to breathe using a mechanical ventilator. So when we do that, first we will put you to sleep. So you don't feel anything, you won't feel the pain of the tube, you won't realize that we're putting in the tube, you'll be relatively comfortable. We will then insert the tube, and during the insertion is what we call an aerosol generating procedure. So aerosolization basically means that the forming of small droplets from the mouth and the respiratory tract, and this aerosol is what is actually how COVID-19 actually spreads. So it's these little droplets that if it gets onto our hands and we touch our noses or our face, that's where we get it. Hence, when we are doing this procedure, we have to ensure, being as close as we are to the patient, we have to ensure that we're all protected. So we want to prevent the droplets from coming onto us. So that's where you see all of us will be wearing all the personal protective gear, the face shields, the hoods, some of us wearing the goggles, right? And of course, the most important actually is the N95 mask.
Yeah. So with regards to the PPE, personal protective equipment, could you articulate for us how difficult it is being inside one? Okay. From the process of putting one on, how long you have to wear it on average one day, up to removing and discarding of the PPE safely.
Yeah, so personal protective equipment is what keeps us safe while we try to treat our patients. So one of the things, well, you've asked quite a lot of questions there. Let's go through putting it on first. Now, when you're first exposed to the need for personal protective equipment, it's not something that we train for every day in our day-to-day before this pandemic, right? It's something that we do, we know, we are aware of. Never thought it would happen to you because you do not actively deal with something of this sort on a daily basis, right? So when we first faced the COVID-19 pandemic, when it first came to our shores, then we realized that, okay, we've got to protect ourselves. Again, learning from the experience of the other countries that are around us, and from the experience and the guidance of our infectious disease control specialists, our infectious disease specialists, and then our occupational safety and health specialists. So we first had to do a lot of training. We had to relearn and practice, because knowing what to wear in what sequence is one thing. You also have to ensure you're wearing it in the correct way, okay? And you have to ensure that when you are removing it, so we call it donning, to don the PPE, and to doff, so donning and doffing sessions. So we had a lot of training sessions organized by my department. We trained everybody that could possibly be involved, the nurses and all. Initially, you are a bit awkward, but after a while, you get very used to it. It becomes quite fairly easy, quite fast. So when it first started, it takes you about 15 minutes just to wear the whole assemble, right? About 15 minutes just to dress yourself, yeah? It takes you another 15 to 20 minutes just to remove yourself. Removal is very, very much slower than when you put it on. Because when you put it on, the items are clean. So you're not so particular about what you touch. But when you're removing, when you're doffing, that is the time where most of the contamination can occur. What we call a breach in the PPE. So if there's a breach in the PPE, it could mean, if it's a high contamination, it could mean you are off work for 14 days or until your swabs become negative. And the limited amount of staff that we have, you do not want to breach, because you're going to put the rest of your friends and colleagues at a great inconvenience. So we spend typically, my center, we are very lucky. We have this thing called negative pressure rooms. Okay, so negative pressure rooms means that the patients are safe inside and it's negative pressure, so the air is being sucked out. So the air tends not to come out. So we can stand for outside looking in at our patients. So I do not have to don when I'm doing my writing and doing my documentation. I just have to don just to go in to do the examination, to do the scans, the echocardiogram, just to speak to the patient, to check up on the patient, or to do certain procedures to the patient that I have to don to go into contact. If not, I can do my documentations outside. This was in the early phases, but at one stage we had too many patients and we didn't have enough negative pressure rooms. So because of that, then we had what we call an open ICU. Now, most other places have open ICUs. Negative pressure rooms are premium. It's not often that we get a lot of it because it's got certain requirements to it. So when it was an open ICU, you typically would spend about 2 to 4 hours inside there, right? Donned up. And the one statement that I will tell you is hot. You see a lot of pictures on Facebook and of everybody all after they have removed the gowns and you're drenched in sweat. It's very typical for us. On the other hand, is every time you don and you doff, you remove your PPE, you have to take a bath. Okay, so you are taking multiple showers per day. The minute we see patient once in the morning. After that, you come out. You take a bath, you will have your lunch, take a break, and then in the afternoon you go in and see the patient again. This is provided that the patients are stable. So if they're not stable, then you'll be in there longer, or you'll be in and out more frequent. So typically we will be in and out about 3 to 4 times a day. So if it's 3 to 4 times, means 3 to 4 baths extra before than what you would normally do. So with the PPE and all, the other thing that you get is great discomfort because the mask and all, I'm sure everybody is wearing face masks now outside. So it's the N95 is very much tighter seal and it's more difficult to breathe.
Okay. Are you afraid of getting an infection under such a high-risk environment? How has living with family in the same household changed being a COVID-19 frontliner? Did your family agree with your decision to support the front lines or get no choice?
So, well, it's let's address one question at a time. The first one is in terms of what do you feel? There's a lot of anxiety definitely at the start. I think it's human nature to fear the unknown. So when COVID first came in, definitely we didn't know a lot about it, and everybody was just afraid that, we watched too much Hollywood movies, we watched too much Korean drama. So everybody felt that, oh, the minute I'm getting, I'm going to turn into a zombie, or, I'm going to fall so sick. So there was a lot of fear, and we didn't know how to protect ourselves. But like I said, with training, with a lot of guidance from the infectious disease people, the OSH, and the seniors in the department, with some experience from the SARS outbreak previously. So we got together, we did a lot of heart-to-heart, I would say, a lot of counseling, a lot of discussions, and reassurance. So that and the experience that we got while we started caring for the patients, when the patients started coming into ICU, that experience actually helped alleviate the fears. As for the family, well, I was not as affected as some of my friends. My parents are in Penang, right? I'm here in KL. So it was still a change. Every time I come home from work, before you would greet your loved ones and whatnot, you would essentially ensure that you take another bath, put all your clothes outside in the special bag, you wash it separately from everybody else. That's what we were doing. Some of my friends actually opted while they were serving in the COVID ICUs not to go back home to their family, to their children and their elderly parents. They rented places outside. There were a lot of very generous hotels that allowed us some free stays, especially some of my friends from HKL. So we all had to adapt, but we did it knowing that this is part of our service. This is essentially part of our job and part of our responsibility as a doctor, as a critical care specialist per se, or a person taking care of the patients in ICU. So family is of course very supportive. Well, we know what you're getting into. Like you got us into medicine. We all went into medicine knowing that this is what we want to do.
Yeah, that's good to know. It must have been very stressful on top of the longer hours doctors and nurses must have to clock in during this period. How bad was the situation in Malaysia during the wave which climbed exponentially in March? were we ever at the risk of not being able to cope with the caseload and had to choose between young or elderly, like what was reported in Europe?
I think we initiated the MCO early enough. Even at its peak, our numbers in ICU total, I think in the entire country, we total at the most 150, if I'm not mistaken, 150 or 200 maximum, the highest number of ICU patients. The ones admitted, yes, it was quite high. We actually, with the MCO coming in early enough, we never reached a point where we reached so-called our maximum numbers of ventilators. We managed to have, through a lot of collaboration, a lot of help, the private sector stepped up to loan us ventilators to the government hospitals. The government hospitals definitely, we started pooling our resources. We cut down and reorganized ourselves to COVID, non-COVID hospitals. We decanted our patients. So there was a lot of effort being done, and I have to say, there were hiccups, definitely. I don't think any country can say that they have done things perfectly. But I think we've done pretty well. We managed to control the numbers. We managed to ensure that we never came to a point where I had to let people, I let people die because I did not have enough equipment. We were prepared in UMMC. We were prepared to go up to 12 beds in the first phase. We had phase 1, phase 2, phase 3 plans. Plan A, plan B, plan C. We were prepared to go up to 22 beds. At the peak, we were at, I think, 10 patients at the most. So it wasn't. We never really hit our maximum what we could do. That would have been bad. Sungai Buloh, I would say Hospital Sungai Buloh were champions because they took the brunt of it. They took most of the patients with the support of HKL and UMMC for KL region, which is probably the worst hit. With regards to coping and all that, I do have something to say about like my family and all. One of the things that probably will hit you most is that you try and avoid seeing your grandparents, your elderly parents, and whatnot. So video calls become very more frequent. My grandmother is in KL. What the saddest thing is, I bought her face mask. So I went over to look for her. She lives nearby. So I went over to pass her the face mask, but she cannot come out and see me. So she's standing in the door right inside and waving at me and say, I made you this, I made you that for you to drink. Please take care of yourself. But she cannot come out and greet me. It's so sedate. It's very sad.
Contactless delivery.
Yeah, it's contactless delivery. So she was so sad and all. And then she keeps asking, make sure you are sleeping, make sure you're taking care. But she's 90 years old. So I do have to be careful.
Yeah, my grandmother lives with me as well. And actually, for the first 2 weeks since the MCO was enforced, I didn't go near her as well because the nature of my we're staying in the same home, but then I can't go near her. But due to the nature of my job, I do meet a lot of people. I travel a lot, so there's high risk. I meet people who actually meet a lot of other high-ranking people, and they travel a lot. So there's a lot of high risk. So for the first 2 weeks, I stayed away from my grandmother to be sure. But then now, I have 4 or 5 weeks with her, so that's good lah. She's also 90 plus already.
So when we are living with all with our oldies and all that, it's a different level with it lah.
Yeah, I think humans, we are social beings. So I think it's it's a very difficult time for people. I mean, although I'm an introvert, but I still do feel it. It can be very challenging because you're not able to hug anymore. There's no contact anymore. So I believe the doctors and nurses in the hospitals, you cherish that human touch to actually feel that you're not alone. So I think
it makes you appreciate it very, very much more. You take a lot of things for granted that you hardly visit, or you say that, okay, it's okay, next weekend, this weekend I got something, next weekend. But when MCO comes about, then you realize next weekend you don't know whether it will come or not.
Yeah. Well, video is definitely not going to cut it lah.
It's not the same.
Personal touch. So, well, in the event that someone contracts COVID-19, what should he or she expect in terms of treatment for the respective stages? I understand there are 5 different stages.
I won't actually say stage, but there are 5 what we call severity, degrees of severity. Okay, so what we have seen is the first one is probably asymptomatic, 2 mildly symptomatic, 3 slightly more symptoms, 4 you need some oxygen support, 5 you need ventilator support, you need life support to help with the breathing. It's so bad. So again, we look at the numbers. We've seen that about 5 to 10% of all patients that are infected will end up in category 5, right? In category 5. The majority of it will be in 2 and 3, right? And the so-called, the science of it is trying to prevent those in category 2 and 3 from going into 4 and 5, from deteriorating. So now everywhere, the whole world is still searching for a treatment, for cure. The much touted hydroxychloroquine, initial reports out of France, out of Wuhan. Wuhan was a bit guarded. The French papers were very optimistic about it. They saw quite good results. The bigger studies now have come out and say that actually there's not much difference. Hydroxychloroquine is not without its side effects that we monitor very, very closely, because it can affect the heart and the conduction. The heart, it slows the heart rate down quite badly. It can actually predispose towards a heart attack. There are other drugs, relatively experimental. We were using one of the newer antivirals that was used for HIV treatment. Again, the same complication with regards to the heart and liver impairment. That was also a bit difficult. And of course, then the big trial that came out is remdesivir. That's ongoing now, but again, you get conflicting reports. Some say it's good, some say it's no good. What I can say is this: the principles of management is to ensure symptomatic treatment. We treat the patient as well as we can to ensure that the patient does not deteriorate. We control the patient's the amount of fluid that goes in. We give the treatment. We treat the patient with antibiotics to prevent a secondary infection. We do a lot of physiotherapy. We tell the patient how to breathe better, how to lie in a certain position. So the few things that have worked was prone positioning. Those that were in category 4, 3 to 4 to 5. 3 to 4, 5 as well. What we found is that if you lie on your tummy, and it's prone position, and you breathe, right, for a longer period of time, it actually helps to expand the lung and improves the oxygenation of the patients. So if we do what we can with the available evidence. So everything is evidence-based. We have to justify why we are trying or we are using certain medications. Our Malaysian guidelines still state that in category 3 and 4, you would start the patient on hydroxychloroquine. The other things that we were starting, or we started our trials, especially in UM, we have started, and we were using on again experimental basis led by Prof. Adiba. We were using something called tocilizumab. It's a monoclonal antibody. So essentially, it's trying to suppress the immune system, because it was the over-aggressive immune system that was destroying the lungs at that point in time. So we've had some good results, but again, this is our local our local reports and things like that, we do have to do proper trials. We have to do proper clinical trials, randomized, and we have to see in more patients before we can actually safely say that this is a drug of choice for treatment.
There's increasing talk about the use of convalescent plasma. What is convalescent plasma and how effective is it as a treatment method?
This one is a question that a lot of us are arguing, still up in arms about. Convalescent plasma essentially is taking the plasma of a person that's recovered from COVID-19, right? You take the blood, you extract out the antibodies that they have developed against the COVID-19 and injecting it into another person that's affected with COVID-19 and hoping that these antibodies will then boost the immune system and enable the sick patient to actually battle the disease. Highly experimental. That's my first statement. Highly experimental. It is essentially like a blood transfusion. There's always a risk involved, right? For reactions. The other thing is the evidence. I may not be the best person because even though we do not know what's the latest ongoing trials, but the reports coming out of it has been, I would say, still on the fence. It's still iffy. It's not something that we are practicing actively here in Malaysia.
Okay, so there are countries such as Sweden. They have a different approach. They are adopting herd immunity. UK tried that in the beginning until their numbers skyrocketed. Is there any danger for relapse in patients who have recovered, as reported, in South Korea and Japan?
Now, again, given that this is a new disease, it's not entirely clear. The ones that were reported in Japan, not in Japan, sorry, the South Korean report, further studies after that, actually they showed that it's not actually a new infection or reactivation, but it's just that the what is that called? That the dead virus is still there. And because you're doing a PCR test, right? A polymerase chain reaction, detecting genetic material, even if it is not active, the genetic material is still present. So they were detecting that residual genetic material. So even here in Malaysia, we have had some reports of that. You have some patients that have become negative, and then a week later, when they go and repeat the test, they are positive again. However, they are asymptomatic. Most of them are asymptomatic or fairly mild symptoms. There's not much. It isn't a active infection as before. So my belief is probably just a residual. It's just the residual virus, the genetic material that's still there that hasn't been cleared by my body. I do not think that it's actually a new infection or reinfection, but we still need to study it very, very much more. There are some reports, I was reading, there are some reports even from China about reactivation or a new infection. It's still possible, right? WHO initially was very hopeful that, once you get the infection, you will develop antibodies and then you will not get the infection again. But it also go the way of dengue, right? Because there are so many strains, like dengue has 4 strains. Coronavirus, initially they said 3, now then it went up to 7 or 8, and then now some are saying 14 strains that are running around the world. Okay, and the antibodies that you develop may not be covering every single strain, right? There's always that risk involved. So I don't know whether herd immunity would be the way to go. Some, again, we've got very conflicting views. You agree to disagree in that sense. Some people have said, using the Swedish model, where they said that they would only isolate the sick and they will protect the most vulnerable. But we have seen that if you compare their death rate, their mortality rate, and those countries, the Scandinavian countries around them that actually went into a lockdown, their death rate is very much higher. You're talking about, I think, 4 times higher last I checked. Again, I probably need to go and update that, take a look at the numbers again. But yeah, it's probably about 3 to 4 times. You can just look at the way the UK went. They tried herd immunity initially, and then now they got flooded, and hopefully things improve as well. So the so-called elusive herd immunity, I think, is still up in the air. Our best chance of surviving this at this current moment is still to practice good hygiene. Follow the Taiwan model more than anything else. Where wear masks, everybody going out, wear your mask, right? Ensure that you wash your hands often. Please do not wear gloves. Wash your hands often, and avoid all the crowded places. Be a little bit more an introvert, even though as much as you would like to see all your friends and families in big gatherings, because we know Malaysians love nothing better than, visiting each other, right?
Yeah. Okay. So before we go through some of the questions that the audience have posed to us, are there any memorable moments you would like to share, related to this pandemic?
I would say there's actually quite a few. We've become quite good. You become quite, how would I say it? You become quite involved in the lives, and you become quite close to the patients and their families. We've seen a lot of wonderful things happen. So my few memories with my patients was we had one of my patients in ICU. He wasn't intubated, quite badly on the ventilators. Not on the ventilator, but on oxygen support. But he was very motivated. He was very thankful, a lot of gratitude. He was because we were one of the few people that he could talk to, and he was very positive. So he's helped. He was very willing to listen to our advice. He followed what we needed him to do. And even after this, he's still in contact with us. He's updating. He tells me, "Morning, doctor. How are you?" He's was very happy. And a lot of our patients came out of ICU that recovered were actually very grateful for the care that was received. There are also very heartbreaking stories in the sense that some of them, the day that they brought their parents into ICU would be the last day that you would see your parent, your father in our case, the one that died in our ICU. We cared for him about 3 weeks. Came in pretty bad, and you are not able to see the parents every day. They're crying, they're calling us, is it getting better? And we're breaking that news of the parents getting worse, the father was getting worse, and all. We were updating them. And the sad part also were they themselves were COVID positive and were admitted in the wards. So they were trying to, of course, get the information to relay to the other family members while they themselves were battling the disease in the wards. Another heartwarming thing that is very good was you could see the community coming together. At the early stage, nobody stockpiles PPE, right? Nobody stockpiles PPE. We buy and use as we need. And like I say, one whole suit, normally we would wear, if it's on COVID, we would probably be using that whole suit, maybe 4 or 5 suits a month if you get a TB patient. But now you are using per person 4 to 5 suits a day. So the amount that was needed increased tremendously. And I was contacted by a lot of very wonderful people that have contributed tremendously, bringing in PPE for us, sewing the headgear, sewing the suits for us, because even if you've got money, you cannot buy, at this current moment, because there's no production. When COVID suddenly exploded in Europe and the US, in fact, there were stocks that were already bought and purchased for us here in Malaysia by some of my donors, confiscated and sent over to the US, because everything could not come in. So it was actually pretty bad. But our community, I would say Malaysians are amazing. We've stepped up. The donations coming in, you feel very much loved. There was a lot of food coming in. There was a lot of not just the PPEs, but a lot of support as well. I received one wonderful picture from one of my patients, a very young patient, said, saya duduk di rumah untuk kamu duduk di hospital untuk saya, stay safe, Dr. Kevin. That kind of things are very heartwarming. It also gave us a lot of strength. So that gave us the ability for us to carry on in ICU, even though it was very lonely, because there's only one of us that's on call every day.
It's still good to know that there's many good people in the world.
Yeah, definitely. Malaysians especially.
Okay. All right. So we're going to share the first comment by Sharina Ng. She's asking, being a frontliner, do you all get monitored or tested for safety to make sure you are COVID-19 free?
Yes, we do. Okay. So we have set up a system, especially here in UM, in the University of Malaya, and most centers. Every morning I will receive a love note from our dedicated OSH, Occupational Safety and Health Officer in my hospital, right? Okay. They will send you a love note to say, hi, how are you today, right? Do you have any of these symptoms? If you do, please say yes, and we will contact you for further testing. If ever we are sick, we have a dedicated clinic available for us to walk in. We can get a test at any time. UMMC and UM is probably the fastest in terms of testing. Most of the KKM hospitals and all, you wait 24 to 48 hours to get your test results. In UMMC, if you send your results in the morning before 9 o'clock, by 2 p.m. I got my results out already.
Okay. All right. So the next question is from our CEO, Dr. Kong.
Big boss. Okay.
If we are monitoring temperature of visitors, what temperature should we take as feverish? WHO seems to take 37.3 degrees Celsius. I think our MOH says 37.5 degrees Celsius, and the other literature says 38 degrees Celsius. Do we have standard in Malaysia? What is your recommendation?
Wow. Very difficult question to answer, Dr. Kong. If we follow the definition of fever, febrile, right? If you have a fever, it's 37.3. That is the definition. That is taken as having a fever, temperature more than 37.3. So if you want to be safe, you want to err on the side of caution, anything more than 37.3, screen. Take it as a fever and screen. At this point in time, it's always better to err on the side of caution rather than to take a higher number. 38 degrees and above is what we call ICU fever. In order for me to deem that it is significant in ICU, I will take 38 degrees, right? So it's still up to our local guidelines, and I would follow at 37.3 lah.
Okay. Here's a follow-up question. Are we testing enough? At around 7,500 tests per capita, the daily reported infection figures reflective of the real situation?
You're going to put me in trouble with G. Okay, if we follow WHO numbers and their requirements, yes, we are testing enough. That is the official statement. That is what if we follow the standards that have been set, we are testing enough. If you ask me as a Malaysian, as also a fellow rakyat that is going to be very afraid of the MCO being opened, and and we're going to have all these people. Already we see the first cluster among our hospitals, among the industry. The one that was reported today in Rembau, the dust in Rembau. They were at the factory, they have 38 people that are positive. I don't think we are testing enough for certain marginalized groups. We have done enough for targeted, definitely. We have, it's been pretty amazing that we managed to test as much as we did with the first big cluster of the Tabligh group. They were very, they actually came forward. Most of them came forward, was tested. We are testing everybody that has returned. That's pretty good as well, from overseas. But there are certain groups that probably will fly under the radar. And we do have to realize that we have very large population of illegal immigrants here in Malaysia. These are people that, if we were to look at official data, do not exist. But I think all of us have to admit that these are a group that we have to be very supportive of at this time. There's a lot of fear in them because coming out, seeking treatment and all may not be as easy as you and me walking into a hospital. There's obviously worry of retribution, worry of being deported. Of course, doctors-wise, we are very neutral. We will treat everybody the same way, right? Whatever the status. So we'll do what we can and do our best, but I think we can be testing more in certain groups. I think DG has also said that as well. He's come out and said that they will be aiming to test targeted testing, and they will do a lot more of it. We from the Malaysian Medical Association is also working actively with a lot of groups to try and see how we can help out, how our general practitioners can help out, how the other doctors can all come in and offer our services, how we can test more, how we can ensure that the testing is safe. One thing I will have to say is PCR testing, even though it's the gold standard at this moment, is tedious and it's very slow. It's not the easiest of tests to do, and the sensitivity or the detection rate from a swab actually is not very good. And I think there's one question that I saw here from the live comments by Prakash, by Linesh Prakash, about that.
So maybe we can flash that.
Yep. So this is actually. Yep. So this is actually a very important statement. In ICU, we do 2 samples because most of our patients are intubated. So we do 2 samples. So the first sample that we do is the nasal swab, the typical nasal swab. The second one is we insist on a sputum sample. That means we will insert a small tube down the breathing tube and obtain the phlegm from the trachea and bring it out and send for testing. And between the two, we trust our sputum more rather than a nasal swab. So even most of the reports and all have actually shown that the sputum sample actually is more sensitive than the nasal swab, because the nasal swab is subject to a lot of technique, right? And whether did you actually reach the nasopharynx, the back of the throat? Was the swabbing enough? Did you rub it enough? Okay, and how bad the infection was. If you have a very heavy infection, it's very easy to get a nasal positive result. The asymptomatic ones, a bit 50-50 there. So definitely sputum is better. There's a lot of new technology. There's some tests that are coming out using saliva. Again, how sensitive and specific is it? How sensitive is this is again subject to a lot of more studies and all that before we can officially use.
Okay. Well, I understand the need to find that balance between lives and livelihood, and with most sectors of the economy having reopened earlier this week, will this cause another wave? Can we expect cases to surge again?
This is something that we are all being very afraid of. Everyone is very cautious, right? Um, we have reached a stage where we have stepped down our services or stepped down our level of I won't say preparedness, but how many patients that we're actually treating in the ICUs, in the wards, and all have actually dropped down quite drastically. Most are on the path of recovery. Now, in the last 6 weeks, we've learned how to change or how to modify our own behaviors. The statement from the ministry, the 3 Cs and 3 Ws is actually very important, right? You don't want to go into crowds, right? You want to ensure that you are wearing a mask all the time, you're washing your hands, you don't want close contact. All these things, if we follow what we have been practicing, meaning that we try and take care, we not try to ensure that we do not have too much close contact with a large group of people which we are unsure of the status. I think we probably I think we probably will more or less plateau out. I won't say that we will hit 0 cases. It will be manageable numbers of cases. There is of course fears that we will have the second waves coming from the factories because they will have to work very close together and all. But we've seen that the standard operating procedures have come out. We've told you how to do it, how to screen, how to isolate. We must ensure we don't have jamuan makan-makan and kenduri yang besar-besar. We need to ensure that we are proper. We do not gather in large groups and carry that risk of cross-infection.
Well, I think this is something that a lot of people are asking. How long will it take for things to go normal? Can we ever go back to how things were?
This is a question that I am. This is a question that everybody wants an answer to. Yeah. Everybody wants to go on their next holiday. Air Asia tickets are going to be dirt cheap after this. You want to fly everywhere. You want to enjoy yourself. You want to visit. Your friends, your family that's around. My sister is due to deliver soon, so I'm going to be an uncle. So I want to go over to Australia to see. But things are not going to go back to normal so soon. At the earliest, I would say maybe 6 months to a year before anything comes back to normal. And that is also if we come out with what I would say a rapid antigen testing. If there is an antigen testing that we can do, that would entail a blood test and probably be faster to give you a faster result than a nasopharyngeal swab. We will need to ensure that we have that the infective rate actually drops. Of course, a vaccine is something that everyone is looking forward to, but most experts have told you that if we want to really see a good vaccine, it's going to take us easily half a year to a year. You must remember that up now, we are still searching for the elusive dengue vaccine. The one that was released recently had a lot of a few years ago had problems. Even H1N1 to actually have a vaccine, still not yet, and that was how many years ago. So I don't think we will go back entirely to normal so soon. I will give us another year to 2 years before we can actually say back to normal, or in another year or so we would have adjusted to our new normal.
Yeah. Okay. Looks like we need to wrap things up. So, Dr. Kevin, what can the community do to help frontliners in this war against COVID-19?
I think I said this, I covered this earlier on when we were mentioning, yeah, the 3 C's, 3 W's, very important. Now is the time, now is not the time to, now is not the time to rebel. Now is not the time for us to say that, nope, I'm going to do it my way. What has proven to work at this point in time has been, we have ensured that we have isolated relatively well. We've kept ourselves, kept up our hygiene, worn our masks. We have not gone and had mass gatherings or demonstrations like certain countries that we shall not name here, right? And I think we need to continue this. Let us adjust to the new norm. Let us ensure that we wear our masks all the time, right? And when we are out, avoid going out unnecessarily, and avoid crowded places. Let's wash our hands. The one thing that I'm begging everybody not to do is please do not wear gloves. I would like to, I cannot stress this enough, because wearing a glove creates a sense of false security. When a doctor wears a glove, every time we touch a patient, we wear a glove. When we finish, we remove and throw away the gloves and wash our hands. And if I want to touch another patient or touch something else, I will have to wear a new pair of gloves. So unless you are doing that, wearing that pair of gloves essentially has now become, you act like a carrier, and you have taken whatever that you have touched, that COVID or whatever that you have touched, and carried it with that glove, and you have touched your car, you have touched everything, thinking that you are clean. It is not. Washing your hands is most important. So rather than buy gloves, buy hand sanitizer. Hand sanitizer, wash your hands. Cannot be more important than that.
Okay. Thank you so much, Dr. Kevin, for all the sharing in the past hour. We thank you for your service and hope you stay safe and healthy always.
Yep, thank you for having me, Sean. Yep, it's an honor to be here. Stay safe as well. See you, Sean.
Thank you. There you have it, folks. We are now at the front lines, so we need to play our part now in this battle against COVID-19. Thank you for being with us since 10 p.m. Do join us again next Friday on Science Stream. Same time, same place. Good night and stay safe.